So as we begin to talk about what the course really, what the nursing program, what the Surge Tech program wants us to do, let's give an overview of the infectious process of the way these microbes interact with the human host, right? So as we begin to think about that, right? So you all may have, or maybe not, been watching the news, Nelda, and you may have noticed that there are a lot of things going on in the world. And if you pay just a little bit attention to what is going on in the world, yeah, Nelda, it's pretty sad, right? There's just all kinds of things going on, right? But the one thing that's going on right now is that the infectious diseases are spreading. They're becoming bigger in where we normally would find them. For those of you who have watched, the epidemiological video already, the infectious agents are increasing in the area to which they are becoming endemic, right? Endemic is where they're normally found. And these infectious diseases that we think about them as being forgotten tropical diseases, right? Because they never really used to affect the northern hemisphere, right? Or at least very rarely. But now they become such problem that we need to begin to talk about them. And if we look at these things, right, rabies, American trypanosomiasis, dengue fever, leishmaniasis, Chagas disease, right, echinococcosis, right, we've talked about these already, right, schistosomiasis, ascariasis, cysticercosis, right, intestinal nematode infections, these things we talked about, right? And I talked about, well, these are pretty rare in the United States, but they're becoming more prevalent. Another really great word if you've watched the epidemiological lecture, right? So they're becoming much more prevalent. And so to me, it's interesting to note that there is a shift in what is causing death in the world, right? So if we look at what causes death in the world, you can see heart disease and stroke are up there, but then respiratory infections are number 3. Then chronic lung conditions, and a lot of times these are damage that are done to the lungs because of infectious diseases. And then if you look at number 5, diarrheal diseases kills a lot of people in the world, right? And then you see HIV and AIDS, right? For some reason, malaria is not on here, and I don't know why, because malaria is a big killer of the world. But this is an amazing list of what kills people in the world, right? And you can see that in the world, infectious disease plays a huge role, and that's not even considering malaria. Malaria is in that top 3. Okay, if we look at just natural causes in the United States, look at that, right? It's really different, right? Heart disease and cancer, right? Chronic lower respiratory disease, right? So this is all of the diseases that are linked to smoking or damage to the lungs, right? This is COPD, right? This is emphysema, all that stuff, right? Then you see stroke, then you see Alzheimer's, right? Then you see diabetes, then you see pneumonia, then you see kidney failure. You have to get down to what, number 1, 2, 3, 4, 5, 6, not down to number 9 before you start to see infectious disease, right? Septicemia. Well, septicemia is an old term that we use to talk about infectious agents in the blood, right? And so these are typically picked up in the hospital. So if you think about that for a minute, okay, we're seeing a lot of death associated with septicemia. Well, most people don't pick up septicemia in a community or at their house, right? They only pick up septicemia when they have a really bad injury or a really bad illness and they go into the hospital and they pick up infection there, right? So typically that's the way. Yeah, that doesn't mean that you might be working with individuals who are sharing needles when you're trying to help them with their opioid problem. They're sharing needles, and one of their needles is contaminated with Staphylococcus aureus, and then they get Staphylococcus aureus in their blood. Well, that's septicemia, right? So it's really interesting to think about, how we are so different than the rest of the world. Now, be proud to live in the United States, be happy that you are here living in the United States, where we have a lot of infrastructure. And even though we need to repair a lot of our infrastructure, we have a lot of infrastructure, right? We have clean water, we have sewers, things like that, right? And a lot of countries do not. And so if you think about the two lists, you can really see a comparison about how, cholera kills a lot of people in the world, but cholera doesn't kill anybody in the United States. And so I want to make mention of that, because as you get into your professional practice, you may start to see some of these, and you will, right? You start to see some of these, what we call these neglected or forgotten tropical diseases that we really didn't worry too much about in the United States. You're going to start to see some of these. And especially if you go to another country and help out, right? Because you are of that kind of mindset where you do things here and then you decide, well, I have a little bit extra time and a little bit extra energy. I'm going to go and be part of Nurses Without Borders, or surgical technologists without borders, and you're going to go to these other places in the world and help people, and you're going to see some of the devastation that is caused by the infectious diseases, right? This is important to understand. So we begin our talk with infectious diseases with looking at the skin, right? Now, this is not an anatomy class. I'm not going to ask you questions about the different layers or the strata by which the skin is designed or put together, right? That you had that in anatomy and physiology, right? I'm not going to do that here, but I do want you to know, as you all already know, is the skin, if it is intact, it is a huge barrier, right? And a almost perfect barrier, because very few things can burrow into the skin. And that's an important thing to think about, that you have this largest organ of the body covering the body, and it's hugely protective for us against things that could encroach from the environment and cause us to be ill. Now, the skin has lots of different functions, as you all have talked about, um, in anatomy and physiology, right? It's part of heat regulation, right? It's part of absorption. It can absorb things, but mostly it's going to give off waste, right, through sweat and through the sebaceous secretions that we see, right? It's involved in protection, it's involved in excretion, and it's involved in the sensory perception that we have. And a lot of the way that we navigate our environment is because of the nerve endings that are in our skin, right? And the Pacinian and the Meister corpuscles that we see, that you can appreciate that light touch, right? But we do have infectious agents that, if the portal of entry is open, right, if there's a break or a breach in the skin, however that might be, right, whether it's a scrape, a cut, a nick, a piercing, whatever, right, the infectious agents can move into the skin and cause problems, right? And so the three different modes, or the three different manifestations of infections, and in one case, the last one is an intoxication, is, that they get into the body different ways, right? They can get in through a break or a breach in the skin, right? They can be associated with a systemic infection, like, for instance, chickenpox or herpes or syphilis, right? And they can get into the body, but their symptomology manifests on the skin, right? And then the other way is the organism can get into the body, or not even be in the body, but you come in contact with the toxins that they produce, and the toxins can then affect the skin, right? So what you're looking at here is a picture of the dissemination of infectious disease, right? The infection started here, right? The infection started here. Excuse me, 1 minute. Here, and it's spreading all up here, right? This person is going to be in serious trouble really quickly, right? Especially if they're diabetic, and that's probably why this is happening, is because the diabetic patients do not have a lot of really good sensory in their lower extremities, and so they can become infected, and infectious agent can spread pretty rapidly, right? So if they don't get treated pretty quickly, they might be fighting for their life in a few hours. So it can be hugely problematic very quickly. Okay. If we look at this a little bit closer, breaking a breach in the skin, this is a boil, right? So you can see it's a carbuncle, right? There's multiple foci of this infection, right? You have different foci where the organism has started to encroach, and now you have these different pustules that have developed and have become one big problem, right? This is problematic, right? Compared to a furnicle, if we look at a furnicle, right, it's a very compact. Now, I don't know if you've ever had a furnicle, but this is very small. I mean, you can see how it's spreading, right? But even if you were to touch it just gently over here, there'd be a lot of pain associated with that, right? So these are infectious agents that have moved in because of a break or a breach into the skin, right? Other infectious agents can start someplace else. They might get in the body through an aerosol, like chickenpox, right? Or through sex, herpes, or syphilis. We don't have smallpox anymore. But I don't know if you, Nelda, watched the news this Saturday, and there was a case of monkeypox of a person, and I can't remember where they were in the United States, but they were in a different country, and they picked up monkeypox, which is like chickenpox. It just gets disseminated from, yeah, it get disseminated. Is it Nigeria? Okay, so I didn't know where it was, but I don't remember. But I was mowing the yard, and I came in to get some water, and just real, I glimpsed a real quick little piece of news that basically said there was a case of monkeypox, which we haven't seen in the United States and for years, right? Amazing. But these things get into the body and then they disseminate throughout the body. But their symptomology, their lesions appear on the surface of the skin, right? That doesn't mean that they originated in the skin, but it is an infection that's associated with the skin. And then lastly are intoxications, right? And so here are two different ones, although there are many, right? So the top one is scarlet fever, which used to be a big problem, right? And then we started to treat Streptococcus pyogenes, the causative agent, the etiology for scarlet fever. We started to treat it very quickly and very aggressively. And we don't see very many cases of scarlet fever except for individuals who don't go get treated, right? The bottom picture is called scalded skin syndrome, and the etiology for that is Staphylococcus aureus. And what happens is the Staphylococcus aureus produces toxins that denatures and destroys the surface of the skin, right? It is like a burn. That's why they call it scalded skin syndrome, because a lot of times and it usually happens in infants. A lot of times it looks like the parents were negligent and there was some hot water that the baby came in contact with, and so child protective services almost always gets involved until there's an investigation into etiology, and what they find out is the toxins are present for scalded skin syndrome, right, which is caused by Staph aureus and toxins, right? This is another image of scalded, and we treat it just like a burn, right? So you may have not even have heard of scalded skin syndrome. It's not common, but it does happen in the States, right? So now you know the three different mechanisms by which infectious agents can affect the skin. And we're going to be talking about some specific ones in just a minute. The normal organisms that are on the skin, right? We want them there, right? Because they really outcompete for space and nutrients for potential organisms that might be on the surface of the skin that might cause infections in us, right? But if we think about them, there are a whole host of organisms. This is a short list, but there's a whole host of organisms that are on the skin. And these are the staphylococci, the yeast, the gram-negative enteric organisms like E. coli. Yes, ladies and gentlemen, E. coli is on your skin, all right? And diphtheroids, these are gram-positive rods that don't have any single shape. That we say that they're pleomorphic. Most of them are just commensalistic, but there are a few that are problematic, and we're going to be talking about those few in the coming lectures. So if we think about how microbiome of the skin is affected, right? There's a lot of things that affect it, right? Temperature of the skin, how much moisture is associated with the skin, the pH of the skin, the amount of sweat that is produced, right? The chemicals that are excreted, oleic acid, urea, sebum, lots of different things that are excreted. These all have antimicrobial properties, right? So every time that people use astringents on their face, really what you're doing is you're disrupting the normal protection that the body is producing against these infectious agents, right? And so therefore you make yourself susceptible to coming down with infections that could cause problems, right? Likewise, if you are using a loofah on your face and your loofah is cutting up your face, and then you have pimples after that, and then you wonder why. I use a loofah, oh my God, I exfoliated my face. There shouldn't be any problems. I took off all the old skin. Yeah, but you also cut your face. And with men, the shaving process, right? If you're using a dull razor, you're more apt to come down with a little bit of a blemish, if you will, a zit, or a little boil on your face where you nicked your skin while you were shaving. And sometimes the nick doesn't even produce a little bit of blood, right? But what happens is the infectious agents move right on in and they cause problems, right? And so what we term those problems of the skin that get in through breaks or breaches of the skin is we call it pyoderma, right? Pyo meaning pus, derma meaning skin. The more common name is cellulitis, right? So we talk about cellulitis, right? It just means that there is an infection of the skin, right? So if we think about the way that they present themselves, right, and cellulitis, it can be things like carbuncle boils, pimples, furnicles, impetigo. I mean, you could go on and on and on, lots of different ways, right? But here you can see, again, I talked about a furnicle having a single foci of a single focus of infection, right? Or a carbuncle, you can see three heads of pus there. You can see, right, there's one, two, three, and that's a carbuncle, right? Much more serious. There's a core of infection, right? There's a core of infection that's here, but the infection is spreading radially from there, right? So this can become problematic very quickly, right? And so I want you to know the difference between um, a furnicle, a single focus of infection, and a carbuncle. Okay, questions. But remember, the simplest infection of the skin on the face is called a pimple. For those of you who don't know that, a pimple is really the infection of a hair follicle. And that's can get in to those hair follicles and then cause problems. And if you mess with a pimple, right, if you try to pierce it or pop it, a lot of times what that does is it pushes the infectious agent deeper into the skin, and then you have a problem with either a furnicle or a carbuncle, right? So the two etiologies that you need to know associated with most cases of cellulitis are Streptococcus pyogenes and Staphylococcus aureus, right? Because they are problematic. And where Streptococcus pyogenes is easy to treat, right? Because there is no drug resistance at all, no antibiotic resistance for Streptococcus pyogenes. It can get knocked out with just simple penicillin, right? That's the one thing that penicillin is still really good at treating, right? Therefore, anytime we have any kind of infection by Streptococcus pyogenes, whether it be impetigo or whether it be strep throat or whatever, right, we can still treat with penicillin. Staph aureus is a whole different organism. It has acquired all kinds of different mechanisms to resist antibiotics, right? And one of those, of course, is the production of an enzyme called beta lactamase, and beta lactamase breaks down the penicillin ring. So in most cases these days, we cannot use penicillin at all to treat an infection by Staph aureus. We have to use a lot stronger antibiotic. And in some cases, and for some strains of Staphylococcus aureus, there is no real good treatment, right? And so we have to rely on the old-fashioned way of treating patients, which is going in there and debriding and removing tissue, and in some cases amputation, in order to save the patient, right? And you might think that that is a rare thing, but if you ever go down to Corpus Christi, Texas, when you go into HEB, just look around, and you're going to see people who have lost limbs. And that's not because they were in the military. That's because they're diabetic and they've had to lose a leg or whatever, an arm, because of infection, right? And it is sad, but that is the truth, right? Nueces County, down where I grew up, Corpus Christi, Texas, is one of the largest, is a county that has one of the largest prevalence of diabetes, and we have a very large population down there that are amputees because of diabetes, right? So that is a really great decision if you decide to go into a nursing field that helps educate and treat diabetic patients, because they need a lot of help, and they a lot of times, a diabetic patient, right? While you can be diabetic patient with any ethnicity, what we typically see is our diabetic patients being Hispanic and Black, and they just really do not trust the medical institution at all. And so they need help with understanding why they need to continue to treat and stay on their treatment plan, right? Because if not, they're going to be very, very ill, like my mother, right? Which I will talk about at some point. Impetigo, for those of you who don't know it, I've never come in contact with it, um, is common, right? And it's the etiology for impetigo is Streptococcus pyogenes. It starts out with kind of this um, pustule type of infection, but as the disease spreads, right, the infection spreads, it becomes more crust-like, and this is hugely contagious, right? So if somebody has impetigo, if some of that if some of that drainage, some of that serous sanguineous fluid that's coming out of these pustules gets onto somebody else and gets into the body, then impetigo can spread very quickly, right? Um, so lots of different ways it can be spread, right? But it's Streptococcus pyogenes, right? It is scary looking. You don't know what's going on. Oh my God, does my kiddo have cancer? And I've treated lots of different patients who brought in their kiddos for impetigo and thought that they had cancer. I can't I can't tell them anything. When I see it, I know what's going on, but I can't say anything because I am not the physician. But I go over and we'll talk to the physician. I'll say we have a case of impetigo, and they'll go in and they'll talk about it, and they'll get it treated with topical and oral antibiotics, or subcutaneous or intramuscular antibiotics, and it'll go away, right? So you can see that topical, you can do things like Bactroban, but systemically, you can do a third generation cephalosporin, erythromycin, or penicillin, right? But there's lots of different ways to treat this. It's not a problem, right? So when we're talking about these things and you guys are taking notes, so for me, what I would do is I would write down notes. And the things that you should take away from a slide like this are impetigo, right? That's the infection caused by Streptococcus pyogenes, right? Appears like pustules at first, but then becomes very crusty. Usually is on the surface of the skin, face, and torso, right? But that's it, right? I'm not going to expect you to know every single treatment unless I tell you specifically need to know the treatment for this infectious agent, right? But you need to know what the etiology is, right? What's causing the infection? What is the infection, impetigo? And what does the symptomology look like? What are the signs of the infectious agent? Okay? So if you take away those things from here, then you can see that this exam should not be that difficult. There'll be a lot of memorization, right? This is the one exam that will really be about memorization. There really won't be a lot of true, deep, clinical, um, thinking, because we just didn't have time to prepare you to do that this summer, right? I do a little bit more with it during the long semester, but in the summertime, there's just no time. Okay. Any questions about impetigo? Okay. As we move on, this is folliculitis, right? So this was a case study that I was involved with one of my continuing education courses, and I just borrowed the video. This young lady was going on a cruise and decided to make herself look really good, and so she got waxed, but the wax was contaminated with Staphylococcus aureus, and so when they put it on there and they um, pulled out the hair off of her body, then the infectious agent moved right in, right, and so you had this rash that was associated with it, right? And it spread because of the chafing of her clothes. Evidently, she liked to wear pretty tight-fitting clothes, and so it just spread, right? But this is folliculitis. This is the infection of hair follicles, right? Just like it says. But it's pretty extreme, right? Because you can see how the infectious agent is in those hair follicles. Now you can get treated, right, systemically with, in this case, it was erythromycin, but you have to do a culture and sensitivity. Now, for those of you all who don't know what that is, we're going to talk about that in lab today. But really, a culture is you streak the organism out in a 4-quadrant streak. You look at the organism, you use biochemical tests to identify it. That's the culture. The sensitivity is you do testing to see which antibiotics will knock it out. That doesn't mean you don't start treatment with antibiotics. As a physician, I would start right away. I would look at the organism. I'd say it's probably this, and there are these little books you can find. I think I showed you one of them, right? These, all doctors have one. There's a little book says for folliculitis, one of these organisms, right? If you don't know which one, then use this antibiotic. If you know which one, if you know what Staph aureus, then here are the antibiotic choices, right? But if you don't know, start empirical treatment with this antibiotic so that the infection doesn't continue to spread, right? This is not scary looking. It doesn't look good, right? It's not scary looking. But the next one really is. This is necrotizing fasciitis, right? Necrotizing fasciitis is flesh-eating disease, and there are lots of organisms that are flesh eaters, right? Streptococcus pyogenes, Staphylococcus aureus, Vibrio vulnificus, right? Mycobacterium marnum, Mycobacterium ulcerans. There's a whole bunch of them. A whole bunch. Clostridium perfluorans. There's a whole bunch of organisms that are flesh eaters, right? In this case, the most common organism that we see associated with necrotizing fasciitis is Streptococcus pyogenes. So this young man on the top image had necrotizing fasciitis of the face. They were able to stop the infection. This is after, I think, 8 surgeries, right? And he's going to have a couple more. This is kind of a while back, but he's going to have a couple more surgeries so that the plastic surgeons would build lips around his teeth again, right? But he's lucky he survived, because an infection of this sort, we call this particular part of the body, right? This particular part of the body, including the brain, the pharynx, the larynx, the mouth, the eyes, the sinuses, we call that the triangle of concern, right? Dr. Oz calls it the triangle of death, because he's a little bit more sensationalized, but we call it the triangle of concern, because if you have an infection in any area of this, it can move back to the meninges, right? Or it can move into the brain and cause meningitis and encephalitis. And then there's a huge problem, right? Necrotizing fasciitis, the etiology is Streptococcus pyogenes, the one I want you to know. Yes, Justin. Yes, Justin.
So what causes the Streptococcus pyogenes to, like, what makes it worse so that it causes necrotizing fasciitis versus impetigo?
That's a really great question. So remember I told you, Justin, that everybody's immunology and everybody's physiology is a little bit different. So there's lots of different factors that lead to how the organism, number one, gets into the body. Does it get in through through the mouth? Does it get in because there was a puncture wound? Does it get in because there was a laceration? There's lots of different ways they can get in. So it's a combination of how does it get into the body? How does it establish itself? And then how does our immune system and our physiology interact with it? That leads them, because this is the same organism, right? There isn't a different strain that causes necrotizing fasciitis, then causes impetigo, then causes strep throat, right? They're all the same organism, right? And but it's about how it gets in and also how our body responds to it, how quickly it'll spread. It will lead to us to understand how these organisms can cause different types of infections. My neighbor down the block, he was chainsawing some of his trees a while back, um, and he nicked himself, and he thought nothing of it. Right? It was a little nick. He didn't really worry about it. He put his work gloves on top of the nick, and he came in contact, probably from himself, with Streptococcus pyogenes, and he developed necrotizing fasciitis. Right? So it was a good outcome, right? They debrided his hand completely. They removed a lot of tissue from his hand, and they grafted tissue skin on his hand. So he's got this really interesting scar, um, but uh, but he was able to. He was in the hospital for a couple of weeks, but he was able to survive it. Mostly they kept him in there because they wanted to be sure that they stopped the infection, but also they wanted to make sure that the graft was going to take, right? Because when you graft something like that, you don't want to send somebody home because people just do crazy things when they're at home. Okay, so Justin, I don't really have a good answer for you, but I have the correct answer for you, and the correct answer is depends on how the organism gets into the body and how your body responds to it, right? Yeah. Okay. This is old school right here. This is a Penrose strain, all right, that doesn't allow for the serous sanguineous fluids to pool in the tissue of the body, because if you have that pooling of the tissue of the body, the serous sanguineous, you have the pooling of that that clear liquid that's associated with a wound, right? Then if it pools, you're just asking for trouble, right? This allows for that serous sanguineous fluids to be removed from the tissues. And a lot of times what we'll do is we'll pack the area completely with gauze that's covered with a gel that is antimicrobial. And so the gauze will allow for the protection of the wound site, but also the removal of the serous sanguineous fluids from the body. Okay. So necrotizing necrotizing fasciitis can be really, really scary, right? Here's two other cases where you can see where this is completely, they removed all the necrotic tissue, right? And what they're going to do is they're going to make sure that they have the infection under control. You can see the infection is still spreading here, right? That redness. But if they get it under control, what they'll do is they will pull the skin tight, and then they'll suture it together if there's enough room, right? They have other ways that they can deal with this. This person here did not survive, right? The infection had spread not only to the surfaces, but also had gotten into the internal organs. And so um, the patient expired, right? Fatalities are high for an infection like this. Okay. I had about that I had to deal with um, of necrotizing fasciitis, not on, well, a part of my family, my dog. So my dog, we were playing in the backyard, and she ran after the ball, and she was a little a mixture of pity and shepherd and things like that. So she was an athlete, and so she chased the ball, but she overdid it and she tore her ACL. And so we had surgery to fix her ACL, but she acquired necrotizing fasciitis in the vet office, right? And this is what it looked like when it started, right? Um, and so this is after she started to have high fever and started to have labor, and this happened, of course, on Friday at 9 o'clock. She came to us and she just sat down, and we knew something was wrong. We took her to the vet, and within hours, this is what it looked like. So the vet shaved all her hair, right? So this is me and the vet working on this, and so we cut all the superficial, because it was dead. We cut all the superficial lining of her torso, right? So this infection probably took up about, because it extended to the other side of the body also, and um, underneath her body down here. But this was an emergency vet that we went to, and she was really good. I mean, I was really impressed with her. But we removed that tissue, and then they kept her overnight. And so for 6 months, my wife and I, because I had training on how to deal with wounds like this, and it was really expensive to do this. And I love my dog, and there's nobody else who could give better treatment to my dog than me. So my wife and I, we we after she survived, right, overnight, hit her with IV antibiotics. The vet said we need to keep her at least overnight. Well, the vet and I knew what we were talking about. We were afraid my dog was going to expire, die, because the infection was so bad. But we didn't tell that to my wife, right? Because that would not have been a good thing. But afterwards, I explained to my wife why they kept her there. But we called the next day, and they said she's doing better. So they kept her over the weekend, and then we went over to pick her up, and the wound was open like that. I have pictures where my wife sewed some little vests together, and we bought a lot of surgical pads and a lot of 4x4s and 2x8s and things like that. And every day we would do hydrotherapy with her. We'd put her in the shower, and I would use the shower to rinse off all the entire area that was infected. The antibiotics were kicking in. She was getting better, but it was going to be a long time, right? So this is 6 months later. You can see there's a small lesion here, and after a period of time, um, she recovered fully, and she lived another 8 years, right? But always with this huge scar, because the damage had been done to her body, and the hair follicles and everything else that was on the surface had been completely destroyed. So, when the skin of any animal grows back, it kind of grows back in patchwork, right? The cells are just put down in a patchwork. And then eventually it becomes strengthened, right, with hyaluronic acid. And so eventually she just survived, and was a happy self. Now, when she got to the point where every morning and afternoon when we did hydrotherapy, she knew that she just needed to get in the shower. So she got in the shower. So she helped us. She was never resistant to treatment. And so even after that, this dog loved to take showers. So anytime she needed a bath, I would give her a shower, right? Because she liked the shower. And so you can see the love you can give another species just because they become part of your family, right? So necrotizing fasciitis happens in a lot of different animals, not just humans, but also this is Bandy, my dog. She's passed now, but what a great dog. Any questions? Okay. So yeah, well, I mean, it can be, right? In this case, you know what, James, I recorded the entire process. I have a lot of recordings of me doing all that hydrotherapy, because I thought at some point I would put it in a presentation and do a presentation at diseases in nature, or something like that, where we talk about how animals get infections. And I haven't just done that yet, but I'm thinking I will at some point, because I think it's important to show. Um, yeah, yeah, it's important to show how these infectious agents can affect a lot of different things. This is Erysipelas, right? It's also caused by Streptococcus pyogenes. Justin, do you get it? Streptococcus pyogenes can cause lots of infections. Are you with me? But here you can see that here it's a superficial infection. It's infecting the top layers of the skin, and the person looks like they got a really bad sunburn. But the difference is the infection causes the skin to be less pliable, right? So if you take your hand and push your cheeks, you can feel that your cheeks are very pliable, right? They move with you putting pressure on it, right? With this infection, it's like there's a 3x5 index card underneath it, right? And so it can really cause problems, and usually for the older our older population. So if you go to Walmart and walk around Walmart, you're going to run into at least one person that has this, and they don't know it, right? But just look at their faces, older people, and you'll see this type of infection on them. It doesn't usually kill them because it gets kept in check by the immune system. But it can be very severe. There can be blisters that really form also, fever, and then really serious um, other symptoms that can form. But it's Streptococcus pyogenes. It gets treated with penicillin, right? But a lot of people just do not know that they have it. Okay. So if we think about the skin, right, there's cellulitis, right? There's erysipelas, remember, top layers of the skin, and then there's an abscess. And with the abscess, there's always that core of infection that forms, right? Whether it be a furnicle or carbuncle, boil, whatever you want to call it. Okay? Questions? I did want to cover a few other infections of the skin before we moved on, right? Now, we can't cover everything, right? I just picked a few. And, people are always worried about anthrax. And so I decided to cover anthrax. But anthrax is an infection of the skin, but it's also an infection of the lungs, more serious, and it's also been reported as an infection of the GI tract. Not very rare, but usually it's from people who are so hungry that they're eating carrion. Does everybody know what I'm talking about when I say they're eating carrion? It means that they're eating roadkill, right? They're so hungry, there's not very much food wherever they are, right? Usually in time of famine, and so they're eating anything they can find. And in that case, the spores of Bacillus anthracis get in the body. We're going to talk about cutaneous and pulmonary here, mostly because when we talk about respiratory tract, I don't want to have to say, now here's also a case of anthrax. So just cover anthrax all at once, and then we won't have to talk about it again. So lots of people are worried about anthrax because it is the number one organism on the top of the list for potential bioweapons because it's easy to grow. All you got to have is some background and microbiology and the ability to grow it to make it form spores, and then you can use the spores as a weapon, right? And so we worry about this organism, but the good thing is it's easily treated, right? There is no known resistance of the normal anthrax that you could find in your backyard, right? it Penicillin will knock it out. Penicillin is a drug of choice. There are weaponized forms that have been made by uh, other entities, right? What we call gain of function. Um, and so what that means is that these organisms have been genetically modified, and in those cases, there can be serious threats. But if some of you are too young to remember, um, around 911, when that happened, there was, I think, um, I don't know, there were people sending letters to different people, and in the letters were talcum powder, and then the talcum powder with the spores of Bacillus anthracis. And so I don't remember how many people. I want to say 12, but don't hold me to that. James, maybe if you're doing research, you might look it up. But I think there were 12, right? 12 people who became infected. Um, yeah, there were about 12, I think 12 people that became infected with anthrax, and most of them were like either postal workers or I don't know, some other people who were dealing with these letters. A lot of them were targeting kind of like government officials and things like that. But I don't think any government officials came down with anthrax. So, but some people did. And I don't remember if there was mortality deaths associated with it, right? But it was scary. People were really scared. I had a student who called me. She was taking the course at the time, and okay, thank you, James. So 17 infected, five. I don't remember that. That's a lot. But one of the students called. And she said, "Proveen, I got a letter from." Okay, thank you, James. I got a letter from somebody I don't know. I don't want to open it because you know it might have anthrax spores in it. I said, I'm just going to change her name. I said, Deborah. I said, if you're worried about it, I can meet you. We live kind of close to each other. I said, I can meet you at Walmart and I'll open it for you. I said, but Deborah, do you have any enemies? She goes, no, not that I know of. I said, do you work for the government? She goes, no. She goes, I'm a student. I'm like, okay. Well, I don't know. I don't think anybody's going to target you, but I can appreciate. People just get really scared about things, right? And they just think, oh, they're just sending these out to everybody, right? But it can be a problem. But mostly, it really the way to catch this is because you are coming in contact with livestock. It could be wild animals too, but most wild animals, if you approach them, they're gonna either snort at you or yell at you, and they're gonna run. Are you with me? So, but with livestock, right? The livestock are the natural reservoirs for anthrax. This is cutaneous anthrax. This is skin. This is a skin infection by Bacillus anthracis. So you can see that there's an area of necrosis, right? No matter how it forms. And then around it is reddening, which we call erythemia, and then swelling, which we call edema, right? And so this is classic anthrax. Now, this looks like a lot of other things, right? So you have to do a culture and sensitivity to figure out what's doing it. But remember, penicillin is a drug of choice, right? It's how we treat this, because even though there are GMOs out there, um, I don't think that people are going to use those unless they want to prove something. So let's hope we don't get to that point, right? Because it can be pretty serious. More importantly, anthrax can be much more serious if it gets into the lungs. And so this used to be called wool sorter's disease, because people who shear sheep, right, as they're shearing sheep, um, they're using these little cutters, and they're not hurting the animal, but they're removing the wool from the sheep, right? And they're causing a lot of dust in the air, and they breathe in that dust. Well, in that dust are the natural Bacillus anthracis spores, and so they get into the lungs. Remember, I told you that the lungs, if they're healthy, that they're dark. They show up dark on a radiograph. Here you can see the infiltration diffused throughout the lung, but mostly you can see them on the lateral portions of the lungs, right? And so this is serious, right? Anytime you interfere with gas exchange from the human body, that's a serious problem. Right? But now listen, penicillin is a drug of choice. There's no drug resistance except for those infectious agents that were designed by other countries. And remember, I told you the name of the book was Biohazard, um, written by Ken Elleback. You can get it at Half Price Books. It's cheap. And if you want to read something scary, that's the book you want to read, because you're going to find out all the different weapons that have been created by other countries, right? Um, to try to get an advantage over people, right? So, yeah. Oh, well, that's a easy question. So anytime, Barbara, anytime that you are allergic to penicillin, you should never take an antibiotic in that family. So no penicillins, no cephalosporins, no sulbactams, but erythromycin would work just great, right? As a matter of fact, I consider erythromycin a better antibiotic than penicillin. So if somebody's allergic to penicillin, erythromycin would be the drug of choice. Okay? Questions? All right, let's go on. So leprosy. Guys, Provi, why are you talking about leprosy? It's really rare. It's around. Are you with me? So a lot of times leprosy is going to infect parts of the body that are lower than body temperature. The organism does not like warm temperature. It doesn't like the body, but it will grow on the body, right? But typically it's going to grow in around the nose or around the forehead or around the ears or the knees or the fingers or the toes, things like that, right? So it'll grow in those places that are cooler, if you will, than body temperature, right? And so that's where we see it. Now, leprosy, over the years in the movies, has been depicted as parts of the body falling out and things like that, right? That more like syphilis, right? But um, to me, leprosy really causes a, a chronic erosion of the body, right? Yeah, it can look like this, right? It can look like this. But nowadays we can even treat it, right? We're back, in the 1990s, we were having trouble trying to figure out how to treat it. Now we just treat it with anti-tuberculosis drug because they're so closely related that we can use anti-tuberculosis drugs to treat it, and it works just fine. So if we think about this, you can see here's denuding of the fingers, right? Here is a loss of a limb because of it. Sometimes it shows up as kind of this diffuse rash all over the body, and sometimes it shows up causing this huge amount of deformity, especially on the face. Now, most of the damage that's done to the body is damage that the cell-mediated immune response does, right? It's reacting to the infectious agent that's in the tissues as mounting this huge immunological response, but that immunological response is causing that deformity, is causing that swelling, which then turns into a granuloma. And if you don't watch it, that granuloma can become scar tissue. And so then it becomes problematic, right? The average generation period for one cell is 12 to 14 days. So it's a very slow grower, right? Incubation that's put up by the World Incubation data is put up by the World Health Organization and confirmed by the CDC, says that it's anywhere from 12 weeks to 40 years. And you're saying, really? And the answer is yes, because we've had cases where the only time a person could have been exposed to leprosy is when they were in their teens or early 20s. They were part of the Peace Corps and they went to other countries to help other people. That's when they got exposed, but then they came back and they lived their entire life in Ohio, right? After that, where there's very low incidence of leprosy, but then in their 50s, they acquired leprosy, right? Well, when did they get exposed? Well, the only time they could have gotten exposed is in their early 20s, right? And so, oh my God, now they're 52. Well, that's been 32 years. So you can see the incubation period, right? The BCG, the Bacillus accumbens, um, that's a vaccine for tuberculosis, right? It's called the Bacillus accumbens and urine. So, um, oops. So those are the two individuals who developed the vaccine for it. I misspelled Camille. But anyway, um, and so the tuberculosis, that's the BCG is the vaccine for TB, right? We don't give it in the United States, but it's given in a lot of other places. Mexico, they give it in Mexico, right? But because leprosy is just not very prevalent here, and if we give the vaccine for tuberculosis to help protect against leprosy, then our screening tools in the United States would go away, right? Because we use the tuberculin skin test, right? And if we give the vaccine to people, they're going to have IgG against the organism, and all of our screening tools that are really cheap and effective will not be able to be used, right? So we don't give it here. But that's the vaccine that can be given not only to prevent tuberculosis, but to prevent leprosy. Um, if you live in a country that leprosy is endemic, okay? Leprosy is here in Texas, right? The natural reservoir is the armadillo. It's in the foot pads of the armadillo. And I can tell you right now, as a young kid, my friends and I would catch many a dillo in Corpus Christi, Texas. Right there, out in the monte in the fields, we would go out there, we'd catch them, and we just play with them all day, and then we let them go. Right? We got scratched and pooped on, all different kinds of things. We weren't trying to be mean to the dillo. We just that was fun for kids, right? But I haven't developed leprosy yet. That doesn't mean that you're gonna contract leprosy if you come in contact with a dillo, right? Because they're everywhere, right? I've got a couple that live in my creek bed, and so they're pretty cute to watch, right? There's a family of dillos. Yeah. No, I mean, hold on a minute. So yeah, if you kill a dillo, yes, but not if you like. Oh, oh, because it's the one of the nat. Yeah, yeah. So James, I never know when you're playing with me or not. So yeah. But anyway, there's a family of dillos at Riverside, and I usually take them some carrots and apples when I go there. But they are living right underneath the building, and there's a mama and five little piglets, and they're blind. They're pretty much blind because they come right up to you, and then they figure you're not mama, and then they squeal and run away, right? But I take them carrots, and I take them apples, and also some lettuce, and I put them down, and they like that, right? So yeah, yeah, yeah. Agreed. All right, agreed. Yeah, yeah, Nelda. But they're cute. I think I have a picture of the little piglets that I took at because they come right up to you. They think you're like a mama or a tree or something. They're not very. They can't see very well, and then they figure out, oh, and then they run away, right? So they are cute, Keisha. My goodness, you all. Dapsone is a corticosteroid. It's a topical steroid that people can put on them to help with the inflammation, and that's another thing, right? The prednisone, things like that can also be used, right? And yeah, okay. Any questions about? So I don't expect you to know treatment, but I do need you to know Hansen's disease, right? No, no, Nelda, it is a bacterium, right? It's a bacterium. And it's not okay, dormant. Okay, yeah, it's the incubation period. So I guess you could say that's dormant. So it's the incubation period is really long. So leprosy is also called Hansen's disease. Oops, after the scientists who first talked about it. What makes it come out? Well, again, um, it's going to be the way your body reacts to it. Because some people have leprosy and know it. Other people think they have a little bit of eczema and don't know that they really have leprosy. There is, I don't know if I should say it, yeah, there is a leper colony not too far away from where I live. Now, it does, they're not these big old high fences, and you have to have a special code to get in it. Not like that, right? But there is. I had a student who came to me several years back after a lecture like this, and she said, "Pro V, I'm going to tell you a secret." She goes, "I'm a leper," and I go, "No, you're not." She goes, "Yeah, I am." And she says, "And we live in a community of lepers." She says, "Please don't tell anybody where we live, but we're teachers, we're students becoming nurses, we're all kinds of different people, but we all have leprosy, and we live kind of in the same area to support each other. So we have neighbors that live near us that are not lepers, and they don't even know we're lepers, but we are, right? There's about 12 of us in this little area, and so at the end of the semester, she invited my wife and I to dinner with them, and I came home and I said, hey, hon, one of my students invited us over for dinner, and I'd like to go. We don't need to isolate at all. It's an old myth. Now they're not isolating at all for that purpose, James. They're doing that for support, right? Just to help each other out, right? But and it is kind of contagious, but you'd have to have an open wound, right? But anyway, my wife and I went to dinner and we met a lot of people, and I still see her every once in a while at HEB, and I say hello. But her secret will always be safe with me. So to me, she's just my colleague, right? She's a nurse now. She's just my colleague. But there's been lots of things. Um, no, well, so just think about it. The people are mean to each other. Are you with me? Yeah. So if it ever got out that they were people near you with leprosy, they'd probably be shunned. Just think about what happened with HIV when it first, and even today, right? Um, when the last, I did some volunteer work about 2 years ago at a clinic with one of the docs that I used to work with, and I had a patient in there who came in. She was an older lady, and she asked me if we were helping people who had the H, and I didn't know what that was. She said, you know, the 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 AIDS virus. I'm like, oh. I said, well, um, yeah, we help people. Well, I'm really afraid of that, right? So she didn't want to have anything to do with that. She goes, don't put me in a room where one of them. Yeah. So there's still that stigma of, you can, if you have HIV/AIDS, and you could pass it on to other people. And the same thing with things like leprosy, right? But really, there's nothing to fear. They're just people. Uh, there's nothing to fear. They just have, in this case, um, a chronic infection that they have to try to deal with, because many of them, at least at the time, many of them weren't able to be completely cured. They were doing treatment so that they kept the infection under control. Okay. Toxic shock syndrome. Let's move into some intoxications, right? Toxic shock syndrome. So, oh, looky here, Staph aureus and Streptococcus pyogenes. Here they are again. Does anybody know why this is here? Why is that here? Right? Anybody know why that's here? Yeah, tampon. So, the first time, even though we've known about toxic shock syndrome for a long time, the first time it became widely disseminated in the news. That's right. That's right, Lucia. Is there were three young ladies in the Midwest somewhere who were friends, I think, um, and they were leaving their tampons in for days, right? Which, if you think about that, the the vagina, it is the perfect temperature, has a lot of nutrients, and it has a lot of moisture. It's the perfect place for microorganisms to grow. And in this case, Staphylococcus aureus grew, and it caused toxic shock syndrome in these three young ladies. Now they all survived, right? But I mean, there are cases. The case I was involved in, the last one, was a 14-year-old girl who parents had just recently separated, and the father took her camping because the family always went camping. Uh-huh. Um, no, no, yeah, no. But uh, so you're talking about IUDs, I think, Presley. I think, is that what you're talking about? No, no, they don't. No, they're not going to lead you to cause that, to have that. But anyway, this okay. Yeah, okay, yeah, no, 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 no. Yeah, 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 yeah. Okay, I understand now. Okay, I'm with you. I'm with you. So you just got to be careful. Okay. But in this case, this 14-year-old was in the lake with her father, and got stuck by a, a branch that was submerged, and got stuck in her right hip. And so the father brought her back and to her mom, and that was Sunday evening. Tuesday, the mom bring this. This is a true story, unfortunately. The mom brings the young lady in to our clinic, and she has high. She has hot. She's orthostatic. Right? Does everybody know what I'm saying when I say she's orthostatic? Abdullah, what does that mean? My expert uh, lifesaver, Abdullah. She can't stand. Yeah, okay, fine. That's good enough. Yeah, so blood pressure really changes, right? When you stand or lay and get up, people people faint, right? So her pulse was high, her blood pressure was high, and I went to the doc. I said, I don't know what's going on. I said, the only thing I see is there might be an infection. The doc went in, um, and came back out. She said, I need you to call the ambulance right now. So I called the ambulance, and she said, tell the ambulance that I think I have a case of toxic shock syndrome, and we need to transfer the patient to the hospital real quick. So the doc talks to the mom and says, I think your daughter has toxic shock. There's nothing we can do for her. We need to take her to the hospital to make sure she gets cared for properly. The mother says, oh no, last time she had something like this, you gave her penicillin. Give her penicillin, I want to take her home. The doc says, no, I can't do that. So ambulance gets there. Paramedics are here. Um, the doc basically, and the mom was very, doesn't want to let the young lady go to the hospital. And so the doc that I work for um, says, I tell you what, if you call your family physician and I talk to them, if they say it's okay to release under your responsibility, I'll do it. Right. So mother calls their family physician. The doc talks to the doc. The the daughter's doctor talks to the mother, and the mother says, okay. So the young lady gets taken to the hospital. Do you know that in 4 hours from the time she got there, she went into a coma? Toxic shock syndrome. And the physicians at the hospital, which my doc was the chief resident, right? Was ahead of that area. They were able to get everything under control, and the little girl survived, right? Um, but you know, like a couple of months after that, the little girl comes in with the cake and gives us a cake. True story. And says, I want to thank you all for what you did for me. And she said, it's not my mom's fault. And, 14-year-olds a lot of times are pretty innocent when they say things. But she says that, my mom, she just had a party that evening, and she wanted to be sure that everything was ready for the party. So it's not that she didn't care about me. She just didn't think it was very serious, right? But that gives a lot away right there about, you know, um, what might have happened had the mother not really taken her taking the young lady to a clinic because she didn't think she was that sick. That could be really serious problems. But really, when you think about this, um, toxic shock syndrome is caused by different organisms. The Staph aureus and Streptococcus pyogenes are some of the most common, but there are others, right? But it's the toxin. It's not even the organism. The organism doesn't even need to be in the body. It's the toxins that are produced by it, and it can be pretty severe pretty quickly, right? Well, so James, I don't know. James, you are probably aware about this, right? There's this thing called Dr. Google, right? And so uh, people go on. I'm guilty of it too. I'm like, oh my God, what the hell's wrong with me? so, but people think they know what's wrong, and um, so not only do physicians have to deal with what truly is the signs and symptoms and what's the diagnosis, and let's develop a treatment plan, but they also have to deal with people who think that they have effectively diagnose their own problems, right? Um, so I am very respectful when I go to a physician's office. But I one time with my dog, this cat, this guy, um, who my dog developed necrotizing fasciitis in his office, would not take responsibility. I wasn't going to make him pay for anything. I wasn't going to sue him. I'm just not like that. I mean, I'm not going to sue person just because they made a mistake. But I wanted him to learn from it, and so when he just simply did not want to entertain the fact that my dog got necrotizing fasciitis from his office, I basically said, you're fired, and I went off and with another vet after that. But I just wanted him to say, I'm really sorry this happened, and I wanted him to say, we're gonna make sure that our procedures are looked at to make sure that if we need to make any changes so this doesn't happen again, that we'll do that. That's all I wanted, right? But I think he was so worried that I had enough, and I did. I had enough evidence that I was going to sue him, but that was not my intention, right? But anyway, that's the way it goes sometimes. Okay, scarlet fever. Okay, so here's one where I need you to be sure you understand the symptoms, right? So you have this diffuse rash, and you have what we call a strawberry tongue, right? So if you see this, we should be thinking scarlet fever. It's an intoxication by Streptococcus pyogenes, right? It used to be a really big problem. We lost a lot of kids in the 1800s, right? But as we got better about diagnosing things and about treating infections and intoxications, then we see very little more mortality, death associated with scarlet fever now. We do see it from time to time, but usually it's after about a pharyngitis, so somebody has strep throat. The organism is in the back of the throat or the tonsils and produces the toxins, and then scarlet fever is a sequelae, right? So sequelae, which means comes after, right? And so with Streptococcus pyogenes and scarlet fever is a sequelae. It comes after the original infection because the toxins get produced and the toxins affect the body. Okay, questions. All right. So here are, some of the diffuse rash. Sometimes the skin gets completely destroyed, that it exfoliates, especially from the feet or the hands. And so this, you should be very careful. You should never just rip off that dead skin because some of the skin underneath has not completely healed yet. And if you pull it off, it's like pulling skin off of a blister. And then you're going to have all this open tissue that's not completely healed yet. So you just have to be really careful. Okay. Couple of other infectious agents. Let's talk about conjunctivitis, pink eye. Very common, right? Just about everybody's had pink eye. There are two forms. There's the bacterial that's kind of produces all that goop. Sometimes it's so bad that your eyes are shut tight, and then you just rinse them out with water, and and the 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 mucus gets solubilized by the water, and you can open your eyes, and then you're shocked at how red they are, right? So again, some of the etiologies that can cause that is Staphylococcus aureus and Chlamydia trachomatis, right? Staph aureus probably being the number one cause. The last time I got pink eye was probably about 8 years ago, and it was during cedar season. And this is before I had started taking my vaccine against the cedar allergen. And I remember sneezing into a Kleenex, and I didn't do a good job of making sure that the Kleenex was secure. And when I sneezed, there was a lot of uh, stuff that backed into my eyes, and I got pink eye, right? But usually, it's so contagious, right? that you can pick it up by sharing sharing different uh, drinks and things like that with people, or rubbing against each other, right? But it is pretty interesting. Uh, I had lots of stories, but another interesting story, when I was 18 years old, a long time ago, I was a camp counselor at an Episcopalian summer camp, and I'm an Episcopalian, or that's what I claim. Um, but we were in the process of celebrating Eucharist, and we were passing around the goblet of grape juice, and little Johnny, made up name, had pink eye, and he touched the goblet to his eyes. And so when it came to me, I passed on it. And later on, the priest came to me and said, "Why did you pass on the Eucharist?" I said, "Because little Johnny has pink eye, and I don't want to get pink eye." And sure enough, we had an outbreak of pink eye at our camp, right? So yeah, it's very contagious. You have to be careful, right? Bacteria, right? Viral, uh, oops, this is another type of conjunctivitis. This is caused by Neisseria gonorrhoeae. So in this case, as the mother's coming out of the birth canal, in Texas, we use a little bit of erythromycin ointment, and we put it in the eye. Sometimes we use silver nitrate drops, but we do that so that in case there's any bacteria in the eyes, that we're going to stop the advance of the infection before it becomes manifested. So here you can see is conjunctivitis by gonorrhea. And if you look here, in this case, the eye has been completely digested. It's the person has no eye. I mean, it's there, but it's never going to be functional again, blind, right? And so we need to be really careful. Um, Viral eye infections are look much more serious. So this is usually it looks like somebody punched somebody in the eye or the face, and there's all this hemorrhaging going on. It looks really red, right? Scary, but it it doesn't hurt. It doesn't itch or anything, right? And so this is a little bit different. This is herpes of the eye, which of course led to this person becoming blind. You can see the occlusion of the eye completely. A lot of damage going on with the herpes virus causing this problem, right? So there's one more, right? This is a amoeba. This is an amoeba. So remember, Provy's rules of water are: number one, if it's water stagnant, stay out of it. Number two, if it just rained, give about a day so that the waterway can clear up, then get in the water. And number three, don't get into water that is 80 degrees Fahrenheit or warmer. Go someplace else that's cooler, because that this is a case where you had a young lady get into the water, which was very warm, and had contacts on, and then left the contacts in. Then the amoeba started to grow, took the contacts off, and you can see the damage that was done to the eyes by the amoeba, right? It is seriously, seriously a problem, and people don't know. I don't know why people need to wear contacts when they're out swimming. It just doesn't make any sense to me at all, right? But I guess I don't know why you can't wear glasses and then when you jump in the water, take them off. But I guess people are a little bit different than the way I think, right? Questions? Okay. So that's the end of the material for the infections of the skin and eyes. Are there any questions? Okay, let's go on. Respiratory tract infection, right? So introduction, right? So if we think about this, I'm just gonna I'm just gonna use the trachea, right? And anything that is above the trachea is going to be upper respiratory tract, and anything that's below the trachea, lungs, is going to be lower respiratory tract. Okay. Anything that interferes with gas exchange, um, taking in of oxygen and removing of waste, CO2, from our bodies is problematic, right? And so, again, I'm going to break them up using the trachea as upper and lower respiratory tract infections. And we're going to start with the common cold, right? Rhinovirus, right? There are several different viruses that cause the common cold. Rhinovirus is the etiology that I want you to know. So if I ask, what is the etiology of common cold? You're going to say a rhinovirus, right? Causes about 50% of all colds, right? It usually is an upper respiratory tract infection because it doesn't like warmer temperatures than 30 degrees or 32 degrees Celsius, right? It doesn't do very well, right? So it usually doesn't get into the lungs. Stays in the sinuses, right? Around the pharynx, right? So it causes an upper respiratory tract infection. Common symptoms: runny nose, sore throat, persistent cough, congestion, sneezing, right? And every time you sneeze or cough, the virus is getting put into the airways, which then it can cause problems, right? There's about 100 different serotypes that we know of, right? And due to its small size, it can spread very quickly through aerosols, right? Also, fomites can play a role, but it's not really. So really, let's think about its aerosols, right? But um, if you touch your nasal secretions and then shake somebody's hands, and then they touch their eyes or their mouth or their nose, and the rhinovirus can get into that, right? People don't understand that. People don't understand that the eyes are a really good way for viruses to get into the body. They don't get it, but it is true, right? And so it can become problematic very quickly, right? So it's really direct or indirect contact with the nasal pharyngeal secretions of the body, right? Fomites can play a role, but usually it's the aerosols or the handshaking, things like that, right? So here you can see, if you look at the differences between a cold and the flu, right? So with colds, loss of appetite, sore throat, sneezing, cough, vomiting, right? But with the flu, you have muscle pain, fever, right? Um, Headache, fatigue, and chills, right? So very different presentation. This one is about 3 to 5 days, and then you feel better. This one can be weeks, depending on a lot of things, right? So they're very, very serious. Okay. All right. Let's look at pharyngitis. Pharyngitis is the infection of the back of the throat. Can be on the tonsils also. So it can be pharyngeal tonsillitis, pharyngitis, or tonsillitis. They're all kind of meaning the same thing, right? But what I want you to know here is most of the cases of pharyngitis are caused by viruses, right? So again, viruses causing most of the cases of pharyngitis. But if we then move and talk about bacterial infections, then one organism stands out, and that's Streptococcus pyogenes. Right? Streptococcus pyogenes is the number one cause of bacterial pharyngitis, right? So here are two different presentations, right? This is a kiddo. You can tell by the small mouth, but look at the swelling of the glands back there. So there are no pus pockets. So this little kiddo is a carrier, right? And so we need to treat that kiddo with penicillin to try to get them so that they're not a carrier, because they can then transmit the infectious agent to other people. This is a fulminant case of strep throat. And you can see, again, the glands are swollen back there, but also you can see the pus pockets, right? So this is pus associated with the, now this throat is on fire, right? It is hurting big time. And so in this case, we want to be sure that people understand the difference. Now they're both treated with penicillin as a drug of choice, right? For kiddos, Augmentin, that's bubblegum flavor, really works. But you can see that they have to be treated. Where lots of different infectious agents, yeah, you have to be treated, and then once you get better, you're okay to go back to work or school. With strep throat, after taking 1 day of empirical treatment of antibiotics, you know, penicillin, then usually you are allowed to go back to school or work or whatever. Because at that point, you have the infection under control, and it's unlikely that you're going to spread. So, I mean, spreading the infection, strep throat, can be done through real kind of close contact, right? You see these young ladies talking to each other real privately, but it can be other types of meaningful communication that occur between individuals, right? But you can see that the organism is a gram-positive coccus. It's found in chains. And what type of white blood cells are these, Mr. James? What are the what are the white blood cells that are showing up here? Justin Tino, help.
Neutrophil?
Neutrophils, very good, very good. Because that's going to be a question on not only the immune system, but probably here also, right? Because neutrophils show up when you have bacterial infections, right? So if we think about this, then some of the symptomology that we see associated with strep throat can be the throat can be red with white patches, right? Pus pockets, trouble swallowing, right? Tender glands, right? Tonsils could be red and enlarged. You can have pus pockets on the actual tonsils, right? You can have abdominal pain, and that's usually because the pH of the stomach has changed because you're swallowing a lot of the secretions that the body is producing to coat and soothe the back of the throat, and you're swallowing that, and that changes the pH, which then causes you to have abdominal pain and maybe even become nauseated, right? You can have general discomfort or feel ill, loss of appetite, right? Which is just simply called anorexia, right? In some cases, you might have muscle pain, you might have joint stiffness and a rash, but those are going to be with sequelae, and we're going to talk about sequelae in a minute. It's real easy to diagnose, right? So just by looking at the back of the throat, physicians can pretty much say, yeah, you got strep throat, or some other. A good physician will send a throat culture to be checked for, right? And to me, when they say we want to do a rapid strep threat test, right? It takes 2 minutes. But if I get a negative, I'm going to go ahead and put it on a blood plate and a chocolate plate to see if I can pick up the organism, because the physician is already going to start empirical treatment with penicillin, thinking it's strep throat. But if it becomes out to be Haemophilus or some other organism, I want to be sure I capture it, right? Even though it's not ordered, I'm going to do it anyway, just because I think that we need to know. Right. And so if it comes back, if my plate because I'll stick an A disc on there while I'm doing it. If it comes back that it is Streptococcus pyogenes, even though I had a negative rapid strep, I'm good. I'm just gonna let it go. I'll write it down in my records. I'll write it down on the patient's chart or the patient's record, and I'll let it go. But if it comes back that it's Haemophilus, I will call the physician and said, you know, that case that you had wanted me to do a rapid strep the other day, I haven't followed up, and I've got Haemophilus influenzae back there. I just want to let you know. And they say, okay, thank you. And then I'll ask if it would be okay if the doctor would order it so that I could charge it to the patient, right? Because microbiology, the microbiology lab is a cost center. It is not a profit center. We lose money for almost everything unless we have this big reference lab that we do all kinds of different tests. But for a hospital, we usually lose money. We are there for the convenience of the medical staff, right? So I'll ask if we can charge, and if they say no, we did order it, and that's the way it is. The patient gets free testing, right? But if they say, yeah, go ahead, then I'll charge it, and I'll say follow up, and I'll add $35 or whatever for my time. But other than that, I'm going to do it just because it's the right thing to do, right? And it's going to help the patient, because if they're not going to be cured by penicillin, then we need to be treating them with what's going to cure them. Are you with me? So now, guys, nurses do not break rules, right? A lot of times when I'm in a lab working, people know that I make good decisions, and if I make they also know that if I don't know what I'm doing, I'm going to ask, right? So they leave me alone. They let me make my own decisions, right? I do a lot of times there was a supervisor, right? But I supervise a lab, and there's a supervisor above me, a manager or whatever. But they know that I make good decisions, so I do this. And you know, if I don't get any money from it, I report those extra costs at the end of the month, and I say, but we help the patient, right? And I almost never get criticized for that. Okay, so 10 to 14 days is typical treatment, right? Although it could be a little longer, right? If we see other problems develop due to strep throat. And some of those things could be what we call sequelae. And I want you to know what these sequelae are, okay? So sequelae for Streptococcus pyogenes, sequelae, what comes after, there are 4 of them, right? Scarlet fever, which is an intoxication, right? So that's an intoxication. You have acute epiglottitis, which is an infection. Now the infection moves from the back of the throat to the epiglottis, right? What's the function of the epiglottis? Somebody tell me. What's the function of the epiglottis? Yep. So it protects the lungs, right? So when you're eating, it closes and you can swallow, right? It goes down the esophagus. When you're breathing, it opens up and you can take oxygen into your lungs. So when you have acute epiglottitis, what you have is you have the swelling, the infection of this covering, and sometimes it doesn't work at all. And so then we have to perform a tracheotomy to help people so that they can breathe while they're getting over this infection, right? And then we have 2 others, and these acute rheumatic fever, sometimes called rheumatoid arthritis, and acute glomerulonephritis, those are all due to antibody processes. This is IgG. This is IgG against group A strep. But IgG against group A strep sometimes will cross-react with the tissue of the body, right? It can cross-react with the synovium, right? Or the heart, causing rheumatoid arthritis or rheumatic fever. Or it can cross-react with the glomeruli, the filtering mechanism of the kidneys, which then leads to acute glomerulonephritis, right? Big problems, right? And a lot of times these are due to individuals who have chronic streptococcal pharyngitis as a very young person. It can happen as an adult also, but usually it's a young individual, right? And so, it used to be my age group, right? People who are 50-year-olds. When we were younger, if we had, you know, 4 cases or 3 cases of strep throat in a year, out the tonsils came. Are you with me? We don't do that anymore because we know that the tonsils are so important for the immune response that we will do things to try to make sure that we don't have to remove the tonsils. In severe cases, right, where you had 5, 6 cases of pharyngitis over a year, we will remove the tonsils because they then will add to the possibility of you developing those immunocomplexes, that IgG-mediated cross-reactivity with either the synovia, the heart, or the kidneys, right? And so I want you all to know the different sequelae. I want you to know that scarlet fever is an intoxication. We talked about it already. I want you to know that acute epiglottitis is an infection. And I want you to know that the others, right, acute rheumatic fever or rheumatoid arthritis and acute glomerulonephritis, are due to the anti-group A streptococcal pyogenes antibodies that are cross-reacting with the tissues of the body, and rheumatic fever, the heart, and rheumatoid arthritis, the synovia, and acute glomerulonephritis with the glomeruli of the kidneys. Okay? It's written up here, but in a lot more technical manner than what I just explained. And I'm gonna ask you to only know for the exam what I have explained and not more than that. Okay? Questions? All right. Otitis media. All right. So otitis media is a middle ear infection. We have otitis externa, outside of the ear, the external portions of the ear infection, and we have otitis interna, right? Infections of the inner ear. But otitis media is the bread and butter of any general practitioner's practice, right? Lots of problems with it, right? It affects 85% of children under the ages of 3, right? Happens all the time, right? Very common, right? And it can be treated. However, the infectious agents that cause otitis media have kind of changed a little bit. I'm going to show you a pie chart in a minute that shows you the different organisms, but now Enterococcus is a big player, and so we'll talk about that in a little bit. Okay, so here you can see a normal tympanic membrane, and here you can see one that's inflamed, right? And so we don't want that inflammation process, right? An untreated infection can lead to uh, other problems, including the infection moving into the brain, right? This ear right here, you can see the cerumen, the wax, and the pus back there. It needs to be irrigated to really figure out what's going on, right? It can lead to hearing loss, which can be permanent, right? It can lead to um, having speech impediments, right? Because especially young kiddos, when they um, when they are learning how to speak, they're going to follow the speech patterns that you provide for them, right? So as you're talking and you're saying words, they're learning how to say those words, right? Therefore, if you are a Brit and you're talking with that British accent, your children are going to pick up that British accent, right? If you're from West Texas, you're going to talk with that drawl. You know what I'm talking about? That long kind of, yeah. And so if you're from East Texas, a little twangy out there, y'all, how y'all doing? That kind of stuff. So, so there's different inflections of different the way people speak. You know, and in Boston, it's that party with a ka, that kind of stuff. And so that's not bad. That's just regional stuff, but that's how we pick up our speech patterns. Therefore, you got to be careful when you're talking around kiddos, because if you say a bad word like shit or shoot, right? Then the kiddos are going to say shoot, and they like the way it sounds, so they'll go around shoot, 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 right? Yeah. So I'm not going to say anything about that, but anyway. But and then you might be in church one day, and all of a sudden, I don't know, they drop their prayer book or whatever, and one of them says shoot real loud, and everybody kind of is taken a little bit aback. But these kiddos are innocent. They don't know what they're saying. They just like the way the word comes out of their mouth because they're learning to speak. Okay? And that's pretty important. So here with the little kiddo, it's really hard for them to communicate. They can't say, "Hey, James, my ears are hurting, buddy. I need you to take me to the hospital or take me to the physician," right? They can't say that. So usually with kiddos, 2-year-old, 1-year-old, right? They have unusual irritability. They have difficulties. They might be tugging at their ears, right? They can have fever. They can have fluid draining from the ear. They can have loss of balance. It's an amazing thing how the inflammation of the middle ear can affect balance, but it does. And so if we think about how these things work, it can be hugely problematic. And they can be unresponsive to quiet sounds. And so that is also a problem. And I thought I had my clicker here around here, but I guess I don't. Let me look real quick if I have it. I don't have my clicker. I don't know where it went. Does everybody know what a clicker is? So it's used a lot of times during Halloween and things like that, where there are noisemakers and things like that. Yeah. And yeah, I can't find my clicker, but I found my other noisemakers. But no clickers. I don't know what. Anyway, they make a little sound like clack, And so a lot of times the doc will say, well, keep the child, entertained or whatever, and then behind their ear over here, they'll use a clicker right back here somewhere to see if they can if the child will respond to that clicker, right? And so if they respond to that clicker, then we know that they're not so far. But if they don't respond to that, we know that they're having ear problems. And so during these developmental periods, when kiddos are developing the able to pronounce or enunciate the words, right? You can have these difficulties in the development of speech patterns, right? And so I had a really close buddy a while back. Her name was Corey. I'm not going to say her last name, but Corey. But she would pronounce her name Coey because as a young kiddo, she had these huge problems with ear infections, and so she didn't really understand how to make that R sound, right? Re. It was we, right? Core we. So, she's been through a lot of speech therapists and things like that, but they could just never get it right. And I just finally told her, I said, just accept it. I mean, nobody's making fun of you. So just accept the fact that you are who you are and go on with it. And she took that in stride and went on with it. Right? Which is pretty cool. So if we think about this, right? Um, Children who live in a household where smoking is allowed in the house are much more likely to come down with ear infections than those that do not. Right? Also, infants who nurse from a bottle and are laid down instead of set up to consume the milk in the bottle or the formula are more likely to come down with infection because sometimes a little bit of that milk can be regurgitated and go up the eustachian tube and then have a medium for the bacteria to grow in, right? But children who breastfed, right, have fewer episodes of otitis media because of the protective nature of mother's milk, right, with the immunoglobulins that are in there. And then research has shown that allergy medications, just such as antihistamines and decongestants, might be helpful in some of the symptomology associated with otitis media, but they're not going to prevent or cure otitis media. Okay? Questions? All right. So here you can see that the different organisms, you'll need to do a culture and sensitivity to make sure. You can see, Streptococcus pneumonia, Haemophilus influenzae, Staph aureus, Pseudomonas aeruginosa, Staphylococcus epidermidis, Moraxella, Candida albicans. We talked about a lot of those already. If you cut this up now, about 20% are caused by Enterococcus. Enterococcus has become a really big player in middle ear infections. And not only that, there's a lot of drug resistance in the Enterococcus group, right? So if you think about why we did so much with lab with Enterococcus, you know that it's because Enterococcus is a big player in disease and infectious disease. Okay, nowadays. Okay, questions. All right, let's move on to talk about diphtheria. So you're saying, Provine, why are we talking about diphtheria? It hasn't been here in the United States in over 60 years. That is true. But look where it still is a problem, right? In Russia, on a lot of states bordering Russia, right, in the Middle East, in India, and parts of Indonesia. And so we still have problems with diphtheria in those parts of the world. Now, why is that? Well, I would like to say that we, as the United States, do donate a lot of vaccines to the rest of the world to help them. But a lot of these places in the world that we give these vaccines to do not trust us, right? Because they've had bad experiences with us, or we're not exactly on friendly terms. And so anything they get from the United States, some of these places might turn around and sell them to other parts of the world, or they might just destroy them because they don't trust the United States. It's amazing to believe that even people in the United States don't trust the United States. Are you with me? Think of what's going on with COVID right now. But so what we've teamed up with UNICEF and some other groups, because again, I work for a vaccine company, we team up with those and we give our vaccines that are about 6 months out from being expired, so they don't go to waste. We will donate them to UNICEF. they will rebrand them. They will repackage them, put their own label on it, and then send them to these other parts of the world. And then people are more likely to be able to use that, to utilize them, right? So we typically see this in unimmunized individuals, right? And so you can maybe appreciate that in these countries that are in red, that there is a fairly large population that are non-immunized, right? Um, yeah. So Corynebacterium diphtheriae is the etiology of diphtheria, right? It's gram-positive, plymorphic, has a lot of different shapes. It's not in the spore form and it's not motile. And for lots of us, it's normal. It's a normal inhabitant of the back of our throat. But in order for it to cause a problem, it has to be infected by a virus. And we'll talk about that process in a minute. So diphtheria, Corynebacterium diphtheria, can show up as kind of pharyngitis, right? This is called bull's neck, right? Kiddos got it. Or it can show up as a cutaneous infection. I'm not going to talk too much of the cutaneous infection because this is the more serious one. And so if we think about diphtheria in the back of the throat, what it can do is it can lead to all kinds of problems: fever, headache, sore throat, tiredness, and eventually the formation of a pseudomembrane. The pseudomembrane is composed of dead tissue. It's composed of white blood cells, red blood cells, the bacterium, right? And so it produces this pseudomembrane. That's not pus back there. That's a membrane that's attached to the lining of the larynx, the pharynx, and in some cases the esophagus, right, all the way down. And so here's another image of it showing that pseudomembrane back there. That pseudomembrane is embedded into the tissues. So if you go in there and try to move it or extract it, it's going to make the tissues bleed. So we have to be really careful how we treat that. In other parts of the world who do not have the technology that we do, right? We can figure out that this is a problem or not really quickly. They use old school antibody antigen reactions to the toxins, right? So this is an antigen antibody reaction, right? And so you can see this is a piece of filter paper to which they put the antibody against the toxin, and then they did a streak of different people's cultures of diphtheria. And where the toxin and the antitoxin met, you have these precipitation lines that we call viscous. And that's proof that that the person has diphtheria. That's old school. It takes about a day to do, where we can do it here in minutes, right? But it works, right? So I was talking about the fact that in order to have diphtheria, you have to have the organism, but the organism has to be transformed by a plasmid, and then uh, has to be transformed so that it produces a toxin, right? So the bacterium has to be infected by a virus. The virus has to inject the nucleic acid. The nucleic acid then makes the pathogen so that it produces a toxin, right? And that's a pretty cool mechanism to think about, right? And so this can happen, right? But not in the States because of our vaccine programs. And so I always get individuals, well, why should I uh, vaccinate little Johnny against diphtheria because we haven't seen diphtheria in over 60 years? Yeah. And the reason we haven't seen diphtheria in over 60 years is because of our vaccines, right? Our vaccine program. And so it becomes hugely problematic for these individuals who don't really agree with the vaccines, right? Which now is becoming much more public, is how many people don't believe or are in the vaccine. But prevention really for diphtheria is really immunization, right? It's really about the DTaP, the DPT. Oh, there's all kinds of different ways you can do it, right? So um, if you don't want to get them all, you can get them individual. You can get diphtheria by itself, you can get pertussis by itself, or you can get the acellular tetanus by itself, right? But It's or the acellular pertussis all by itself. So you can get it all different ways, right? But people again are worried that there's going to be problems. I like the story of Balto, right? So the story of Balto, of course, and I think it's the late 40s, early 50s. There's a big outbreak of infectious disease, not only whooping cough but diphtheria in Nome, Alaska. And the only way they could get to Anchorage, where the medical supplies were, was to get there because there was this huge blizzard. Is to get there by dog sled. So Balto represents the dog sleds, and they went and got medications, vaccines, and came back to Nome and saved a lot of people's lives. Right. So that particular route that they did is paid honor to by the Iditarod um, race that occurs annually, and you can look that up and check it out. But it's really about paying honor to these different things. So you can see that a lot of different things in the world have their origins in a microbiological process, right? And so it's pretty interesting to think about. So treatment for diphtheria will be antibiotics, but also we can give um, the antitoxin, and so a lot of times we're just fine. Um, and so it really is a problem with the unimmunized, the non-vaccinated individuals of the world that this is a problem for. Okay, questions about diphtheria, right? Coronabacterium diphtheriae is the etiology. Okay, so what I want you to know about that is you should know about the pseudomembrane formation. That's a giveaway. You should know about the fact that in order for diphtheria to show signs and symptoms, it has to be infected by a virus, and the virus has to change it. So now that the organism um, produces a toxin, which then leads to diphtheria. Okay? All right. We're going to move now to talk about lower respiratory tract infections. We're going to start with pneumonia. So, pneumonia is a word that is used to really mean that there's inflammation of the lungs, right? And there's a fluid buildup in the lungs. Okay. Most of the pneumonia cases that we see are caused by viruses. Now, if we look at just the infections that are caused by bacteria, 90% of all bacterial pneumonia are caused by Streptococcus pneumoniae, right? That's why we spent such a significant amount of time looking at it diagnostically in the laboratory, right? Because if you all are going to become healthcare workers and you're going to be in a rural setting, some of you might be, you might have to do some of this work, right? And so it's important for you to understand some of this stuff. You're not going to remember it all, but you'll have at least an understanding of what this all means, right? Streptococcus pneumoniae is a gram-positive diplococci. It's heavily encapsulated, which its number one virulence factor. So this mucoid-looking organism growing on this plate is alpha hemolytic. It is very mucoid, and so that denotes that it has a capsule, right? Humans mount a significant immunological response to Streptococcus pneumoniae, and that immunological response by our body does a lot of damage to our tissues, right? So it's not just the organism, it's our own cell-mediated immune response. The organism itself is very fragile, right? So if we have Streptococcus pneumoniae causing us problem, we hack up some stuff and we spit it out, and it dries up out there on the sidewalk. As soon as it dries up, the organism is no longer a problem, right? It's not like tuberculosis. Tuberculosis is different. We hack up a little bit of TB and it lands on the ground out there and it's protected from UV. Then, especially like if you're in a garage or a wood shop or something like that, and it's protected from UV, that tuberculosis bacillus can remain viable for a long time. And you kick it up, gets into somebody's airways from the dust, and um, and then TB becomes a problem. TB used to be known as an infectious disease of the dusty trades because that's where a lot of people picked it up, right? It's not like that anymore, right? But if we look at Streptococcus pneumoniae, right, there's it's surrounded by a capsule, right? There's about 83 serotypes, and there is a vaccine against it, right? Used to be called the pneumophage, then it went to become the pneumofax, and now I think it's called Prevnar. But it's made of 12 or 13 of the most common strains, and so then we can get vaccinated. I'm vaccinated against Streptococcus pneumonia. I got that vaccine a long time ago. Okay. Symptoms: high fever, difficulty in breathing, chest pain. The exudate coming out of the lungs has that kind of a reddish pinkish appearance, and that's because of the smaller blood vessels that are breaking apart in the lungs, which then lead to that appearance of that kind of orangish pinkish color in the sputum itself. Right. There are some individuals who are more susceptible to infections of Streptococcus pneumoniae, and that's alcoholics, because alcohol will suppress the immune system. Right. I never get it. Right. Um, People right now with COVID-19, they're going to these huge parties. They're drinking a lot of alcohol. And if there's just one individual at that party that's COVID positive, and now you've got all these people drinking alcohol and suppressing their immune response, you're going to have a big spreader event um, right now, right? Which is a problem. I don't know if you guys know this, but we're in Austin. We're back in stage 3 of the COVID protocol, um, and some of the other places are back to stage 4. Right. Getting back to this, other other individuals who are more susceptible are the immunosuppressed, those people who have AIDS or taking immunosuppressants or chemotherapeutic drugs because they're trying to deal with cancer or diabetes or a lot of other things, right? And the debilitated patients, those individuals who live a sedentary lifestyle because they're morbidly obese or they're elderly and they have dementia, and so they don't do much of movement at all, and so that becomes a problem, right? Yeah, and there's a lot of them. We're getting older as a country, right? It's a good time to become a nurse because you're going to have a job forever, right? And so you can work in, I don't know, a lot of people want to work in neonate. And so you work in neonate for a while. Maybe that's your love. But maybe you decide you want to do different things and you work in internal medicine, and then you decide you want to work in out-of-home care, and then you want to work in people with memory problem. And there's just all kinds of different specializations that you can do. And that's really a good thing because you'll never be bored. Mm-hmm. Mm-hmm. Yep. 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 Lots of really cool things, right? Streptococcus pneumoniae can be easily identified. If it were me and I got a bronch lavage or a sputum sample and I looked at it and I saw neutrophils and gram-positive cocci and pairs, I'm about 99% sure that it's Streptococcus pneumonia, and I would tell the physician, hey, from that sputum sample you gave me, I'm seeing gram-positive diplococci and a lot of neutrophils. And they might say, well, what do you think? I say, it's Streptococcus pneumoniae. Start treating for that, right? But then I would follow up, and I would, if I hadn't done it already, I would put it on a blood plate with a P disc on it, and hopefully I'll get my confirmation the next day. Right? Treatment drug of choice is penicillin. Okay, it's a strep. There's just not that much resistance. Right? Good. There's some vaccines available. Right? Other etiologies that cause pneumonia: Klebsiella pneumoniae, a gram-negative enteric. Right? We typically see this in alcoholics and the homeless population. It's much more destructive. It's very destructive. Right? And so your lungs could be completely damaged within 48 hours. And sometimes lungs can get so damaged that you might have problems for the rest of your life. Okay. Haemophilus influenzae. This is another really great story um, about vaccine. So we used to see it as a problem in kiddos. Haemophilus influenzae. We started giving the Hib vaccine, and now it it's not a problem. And then mycoplasma pneumonia, walking pneumonia, milder case, right? So if you go to the ER or a physician's office and they take a chest X-ray and they say you have pneumonia, and they start treating you for Streptococcus pneumonia without any further workup, very nicely ask if you can have erythromycin, because mycoplasma pneumonia does not have a cell wall. And if you give penicillin against it, it's not going to work. But erythromycin will knock out not only the mycoplasma, but also it'll knock out all the streptococcus also. So it's a good drug. Okay. Questions? Yes. Do you have a specific incidence of that, Barbara? So
Um,
there's
I just
probably,
I just found
go
out
ahead.
that one of my cousins is in the hospital with some form of pneumonia, and now she's having like kidney failure or something.
Okay, that's probably a different thing. That's probably due to the immunoglobulins attacking. I'm really interested in knowing what happens, Barbara. Oh my God! For one thing, Barbara, I pray for a good outcome for your family member. Okay, but if you decide you want to share that with me later on, I would like to talk about it if you want to, because I'm always interested in what happens when these kind of things happen. Okay, so I'm gonna back off my yes because it looks like there's something nephrotoxicity. Oh, from an immune. Okay, so yes, that is. Uh, so I'm hopefully they're giving your cousin dialysis to try to get that toxin out of there. But yeah, that is due to an antibiotic. That is true. Okay. Oh, I hope everything's gonna be okay. I really really hope so. Okay. Any other questions or comments? All right. So another interest. We'll go for another 10 minutes and then we'll stop. Another interesting type of pneumonia is called Legionnaire's disease or Legionella's, Legionellosis. And so this was first, even though we've known about it for a long time, it was first characterized in 1976, where 221 people came down with a fever of unknown origin, right? And so anytime in epidemiology we have something going on, we call it a fever of unknown origin, right? And then we try to figure out what's going on, right? 34 people died. And so they took sputum samples from everybody, swabs of everything. They couldn't find anything. They decided to expand where they're looking for the pathogen. And they CDC sent out people to collect samples from different waters, different things. And a lab person was collecting water from the water cooling vents, cooling towers, and it looked like this, right? And when he collected water from it, he also got a little bit of the activated charcoal in the water, brought it back to the lab, and he put it on a plate. And so happened that when he put it on the plate, there was a little bit of the activated charcoal that fell in the plate, and he didn't remove it. And so just by luck, um, they noticed a couple of days later that there was an organism growing around the charcoal that they had not seen before. And that organism became known as Legionella pneumophila, right? The causative agent of Legionnaire's disease is really interesting because it is associated with water, um, and those different types of instruments that cause the spittle, if you will, the mist of water, right? That could be sprinklers, it could be misters, it could be all kinds of different things, right? So the CDC was working on this stuff, and when they started to figure this out, they noted that there was some similarities to another infection that occurred in the 1950s in Pontiac, Michigan, which they call Pontiac fever. It happened in this clinic. On the clinic, there were two rooms that people were coming down with this fever of unknown origin, but they never could figure it out. And those two rooms were fed by an air conditioning unit that was only for those two rooms. So they went back and they pulled up these biopsies and these tissue samples from these people from 1950s, and they looked at it, and it grew on what we now know as charcoal yeast extract agar, right, to grow Legionella. And what they did was they took the organism, from the Pontiac fever and the one collected from 1976, and they compared them genetically, and guess what? They're the exact same organism. So Legionella pneumophilia is the etiology of Pontiac fever, but also the etiology for Legionnaire's disease. What a cool story that is, right? It's self-limiting, right, for a lot of people, but for some people it can be pretty serious, right? Diagnosis for it is usually done by a fluorescent antibody test. Because they're hard to grow, you have to use a special type of media. And it has about a 5 to 15%. I think 15% is a little high. Let's just say 7% mortality rate. But most of the time, it presents itself as a very mild infection. People think they have a cold, a chest cold, and that's not a problem, right? So they don't get it checked out. And so we think that Legionnaire's disease is underreported and underdiagnosed because of that, right? Any questions about Legionnaire's disease? Okay. Pneumocystis, pneumonia. So, I want you to know a couple of things about pneumocystis, right? Number one, I want you to know that we used to think that it was a protozoan, but RNA finally proved that it's a yeast. So it's a yeast. I want you to know that. Okay, it used to be a protozoan, but now it's a yeast, right? Because our techniques are so good now. It was first reported as causing pneumonia in AIDS patients. So it is a classical marker for being immunocompromised. Okay, I want you to know that. So it's a major indicator for AIDS, right? This organism used to be Pneumocystis carinii, but we changed its name once it became a yeast, and we call it Pneumocystis cerevisiae. Okay, and that's it. There are some other slides here, but that's all you need to know for that. Okay, and then we'll talk about whooping cough, and we'll stop for the day. So Bordetella pertussis, whooping cough, right, gets its name because people who are infected, small kids usually, have coughing spells, and the coughing spells can last 30 or more seconds. And when they're coughing and they're trying to breathe at the same time they're having these coughing spells, sometimes they forcibly take in air through their windpipe, and it produces a little bit of a whoop, right? Yeah. Yeah. Some people say it sounds like a barking seal, right? But it sounds like that, right? And so that's how it got its name, right? The etiology, of course, is Bordetella pertussis, and Bordetella pertussis affects the ciliated cells of the trachea. Now, the ciliated cells of the trachea are involved in the mucus escalator, right? They're involved in moving out mucus from the lungs. So if your ciliated cells of your trachea are not working properly, you're not going to remove a lot of that mucus and debris out of your lungs, and you're going to have the formation of all this fluid in the lungs, right? Which then lowers the lung capacity. And all you have then is a flushing mechanism that we call coughing. And so your lungs start to cause you to cough, hack up stuff, right? But then you cough, and you're coughing and hacking and trying to breathe, and it becomes a big problem. So much so that we worry that when people have whooping cough, that we worry about aspiration of vomitus. That is, as you're coughing, you're vomiting, and you might breathe in some of that, trying to take in a breath, you breathe in some of that vomitus into your lungs. We call that an aspiration. And so it can become hugely problematic for lots of different problems because of that, right? And so if we think about this, then it can be very dramatic, right? So these coughing spells can last for several weeks, right? But the vaccine has been very effective until just about recently, right? I always used to tell people that 15 years ago, I used to tell people that whooping cough was a childhood infection that was a nuisance because nobody died from it. You just dealt with it, right? You either were vaccinated and didn't get it, or you got it and got treated with antibiotics and with a human pertussis immunoglobulin, and then you were fine, right? But it's not like that anymore. the infectious agent has become more virulent. It's become dangerous, right? It can be really dramatic when you watch a little kiddo trying to grasp for oxygen when they have whooping cough, right? Look at the tension that's occurring in this little baby's muscles. Look at that. It is dramatic, right? You can go to YouTube and watch some videos about kids who have whooping cough and what they're going through. That in itself would make me want to be sure that I protect my child, right? Treatment, of course, is erythromycin. That's a drug of choice. And then also we can give IgG, which we call the human potassium serum immunoglobulin, IgG, against pertussis. And it's good. Yeah, yeah. And so, it's really important to me that now, here's the other thing. We as adults are the natural reservoirs for pertussis, right? It doesn't cause a problem in us because we're vaccinated, or at least I am. But other people, right, may not be vaccinated, and we're seeing more cases of adult whooping cough, right? That's your belief and my belief, Lucia, but not everybody else, right? But I hope that you guys are seeing just how deadly these things can be, because now we're losing people. We're losing people to whooping cough, where we never lost people to whooping cough before. And so some of the epidemiology, that we see is we're looking at incidents, right? We're looking at, and so you can see, right, from even 1990 to current, we're seeing this increase, even though it's come down a little bit. Why is that? Well, I think it's on the way back up, right? But look at these spikes we're seeing, right? So we had a lot of cases, then we had the vaccine show up, right? And now we're seeing a spike again. So I believe, this is just my belief, right, that that there's been a change in the bacterium. It's become much more deadly, and the vaccine itself may not be as effective as it once was, right? So we need to, people are looking at the vaccine to see if it's okay, see how we can make it better, right? But again, it can be hugely problematic if we don't watch it, right? And right now, all the focus is on COVID, so we're not looking at all these other things that usually are affecting us, right? And some things are falling through the cracks, which I can appreciate, right? Because we need to get COVID under control, and it seems like it's going the other way, right? So I leave you with the people who are more at risk: pregnant women, babies, if you come in close contact with a known case, if you have a weakened immune system, if you got vaccinated as a young kiddo, but now you're in your early 20s, you might have waning immunity, and then the elderly, which I'm part of pretty quick, right? I'm going to be part of that group in another 10 years or so. If I'm not there already. I don't know what the true definition of elderly is. I don't feel that old, but I'm 50ish. So, that's that can be a problem. Ladies and gentlemen, I'm going to stop there for today. We need to talk about tuberculosis, but tuberculosis is such an important infectious agent that I'm not going to just start it and then finish it next time. So